Hi everyone, it's Dr. Krad. This patient's mother went blind after cataract surgery. She has been putting off cataract surgery because she explains that she has the same eyes as her mom. She said her mom's iris was torn, her pupil was destroyed, and her mom couldn't see anything afterwards. Understandably, she's extremely apprehensive of having surgery. I would feel the same way. Her best corrected vision is 2200 and a refraction of about -17 diopters. Her cataract is severe with 3 to 4 plus nuclear sclerosis. In addition to that, she has retina issues with epiretinal membranes which could limit her potential vision. But here's the retina specialist recommending cataract surgery since they have a poor view of the back of the eye. Eye surgeons are used to helping patients who are nervous. I mean, it's normal to be nervous when having eye surgery. But even on a scale of normal anxiety, she is a 10 out of 10 and on the verge of tears and a panic attack. I take family history seriously, whether it's for glaucoma, macular degeneration, diabetes, or even cataract. I think taking into account family history is important and one needs to keep it in mind when managing patients. So of course, we must approach such cases with utmost care. All surgeries have risk, but I'll be honest, a big part of me is excited. I'm excited at the opportunity to make this patient happy. So join me and let's try to give this patient the best possible result. So we just put some viscoelastic beneath the iris to create space for the Malyugin ring. This pupil is about 4.5 millimeters, and even though it's not too bad, I'm anticipating the iris or the pupil to get smaller during the case. The iris tissue may flop around, and I think securing the pupil border with the Malyugin ring will help protect her iris. Now I'm going to engage the 2 remaining loops of the Malyugin ring with the iris. This case is being performed with topical anesthesia as well as intracameral anesthesia, which is when we irrigate the inside of the eye with some numbing solution. We have an anesthesiologist with us as well. The anesthesiologist is giving her some medication to take away the anxiety. Of course, I'm checking on her to see how she's feeling, and if she needs more sedation, we're giving her more sedation as we go. The anesthesia is essentially dynamic. We can tailor it to each patient. Now that we have a good-sized round pupil with the Malyugin ring, we're going to create an opening in the lens capsule. I'm doing it by hand. I find that with very anxious patients, it's better to do it by hand than with laser because laser takes longer, laser adds a pressure sensation on the eye, and the last thing you want to do with an anxious patient is add pressure or add time to the surgery. Next, I will perform a hydrodissection, and that's when you inject water to separate the capsule holding the cataract from the cataract itself. It's like if you were to separate a grape's peel from the grape itself. And then we're going to spin the cataract within the capsular bag, and that will decouple the cataract from the zonule bag complex. Here we're going to start phacoemulsification or ultrasound energy to eat and break up the cataract. In this procedure, I decided to do a vertical chop technique. After removing the cortex on the anterior surface of the cataract, I'm going to create a little bit of a trench, and then I'm going to bury my phaco tip inside it and use the quick chopper in my left hand to apply a vertical pressure. I lift with my right hand and I push down with my left hand, and you can have an easy separation. I like this technique for denser cataracts, but at the same time, if you have a challenging case, always do the technique you're most comfortable with. But it's nice to know multiple techniques. I usually don't perform vertical chop on most patients. I usually do more of a divide and conquer, but every once in a while I'll switch techniques. And you can see how well this technique is working for this particular cataract. You can even break it into more than 4 pieces. It's separating very nicely, so I'm going with the flow. I'm doing vertical chop. As I remove each nuclear piece, these are dense pieces that I do not want to bump into the cornea, so I'm going to use the instrument in my left hand to protect the corneal endothelium. I'm going to be phacoing away from the corneal endothelium, but protecting it also from the pieces so they don't bounce into the corneal endothelium. In addition to knowing multiple techniques, make sure that if you are going to tackle a challenging case, don't be in a rush. Go slow, but make sure that your technique is perfect. So far, the cataract is coming out fairly easily. Vertical chop is working great, and I'm going to remove each piece carefully without causing any trauma to the corneal endothelium, to the pupil border, or to the posterior capsule. So we're about halfway in terms of removing the nuclear material. And as we remove each piece, we want to be more cognizant of the potential for the posterior capsule to bounce anteriorly. Throughout the case so far, the lens material has been holding the posterior capsule back. And so I'm focusing on protecting the corneal endothelium. But when we get to this last piece, there's nothing to hold the posterior capsule back. And so you want to make sure that you're using your second instrument to guard the posterior capsule from bouncing forward into your phaco tip. And that's it for the nuclear material. Now we're going to do the cortical removal. We switch the handpiece to an irrigation aspiration handpiece. This handpiece, for people who are not familiar, doesn't have the bite of the previous handpiece. It doesn't have ultrasound energy, so it can't eat up or chew on the posterior capsule. Now you could vacuum the posterior capsule and tear it, but it doesn't have the same bite. This is more gentle. So far so good. The cortex is coming out fairly easily. After I remove the cortex, I will polish the posterior capsule with the IA tip and also irrigate it and flush it clean. Sometimes, despite polishing the posterior capsule directly, there's still some lens material on it. So flushing it with BSS, as you can see here, makes it much clearer. Next, we are going to inflate the capsular bag with viscoelastic, and then we are going to polish the posterior aspect of the anterior capsule. This is the Singer Sweep Polisher. So just sweeping across the posterior aspect of the anterior capsule, you get rid of a lot of this lens material. And then we will repeat the same thing on the other side. After the capsule is nice and polished, we're going to inject the lens implant. This is a Bausch & Lomb Aspire lens. And this patient wanted to remain myopic. She wanted to remain nearsighted. And so we targeted myopia so that she can still have some reading vision without glasses, but she will wear glasses for far away. I've really been liking the Aspire lens. It's my basic monofocal of choice. It's considered an advanced monofocal or a monofocal plus, but these are marketing terms for a good modern monofocal that may give you slightly increased range compared to older generation monofocals. And so now I'm removing the Malyugin ring, and I disengage the distal loop, and then I'm going to disengage every other loop. You don't want to pull out the ring before you disengage all of them, because then it can tug the iris with it. And so disengage all the loops first. And during this part of the procedure, the patient may feel some sensitivity, some discomfort, so be very gentle. Now we're removing the viscoelastic from the eye, returning the eye to its natural state. And although the pupil is not perfectly round, I'll show you how it kind of normalizes as long as you're gentle in the next day. Make sure to remove all the viscoelastic and then turn off irrigation before coming out of the eye. Otherwise, the iris can come out with you. And so especially in a floppy iris case, turn off irrigation first. And so this patient, we targeted around a minus 2.75 refraction. She was used to having strong reading vision, so we wanted to maintain her strong reading vision. After the viscoelastic is removed, we want to hydrate our incisions and make sure they are sealed. We want to make sure there's no leaking, they are watertight. So finally, I'm going to test the eye pressure and check the incisions, dry them, making sure there's no leakage, and they look great. Here's the patient after surgery. Of course, they are thrilled, they are relieved, and they are so happy. And amazingly, she can read 20/20 at near without glasses. Thank you so much for your attention. I'll catch you on the next one. Peace.